Hello, welcome to this Medscape education program, Connecting the Dots, Commonalities Around Immunologic Diseases. I'm Dr. Christopher Bunick, Associate Professor of Dermatology at the Yale School of Medicine. I am joined today by two colleagues from gastroenterology and rheumatology to talk about these commonalities around immunologic diseases. Jami and Grace, could you please introduce yourself for our audience?
Absolutely. I'm Jami Kinnucan. I'm Associate Professor of Medicine in the Division of Gastroenterology at Mayo Clinic in Jacksonville, Florida. And thank you so much for having me.
And thanks for having me here. I am Dr. Grace Wright, rheumatologist in New York City, former clinical associate professor of medicine, and just absolutely thrilled to join my colleagues here.
Excellent. It's very rare to have dermatology, rheumatology, and gastroenterology all together, but yet we often manage similar immune and inflammatory diseases. And so we're going to talk a lot about the commonalities between us. And one of the first things is just understanding the risk of treating or not treating patients that have these immune-mediated diseases. One of the questions I'd like to pose is just what is the risk of not treating or delaying treatment of some of the immune-mediated diseases that you see in your clinics? And does early control of that systemic inflammation actually change long-term outcomes across different immune-mediated inflammatory diseases, such as flares, steroid exposures, disability, hospitalization?
Yeah, well, I can start. In rheumatology, we sort of cover all the organs because our diseases manifest across the spectrum. And the two things that really sort of concern me and concern us collectively is that a delay in diagnosis, number one, leads to more extensive disease and often leads to damage that we cannot reverse. And the problem is we can treat the inflammation. We have many effective therapies, but once damage is done, damage is done. And so there's a risk in delaying treatment. And if that is caused by delaying diagnosis, even more so. And then the problem is when you come in profoundly ill, we have to use the things that work incredibly quickly, which tend to be things like high-dose steroids, which seem very magical up front, but carry with them what I call this baggage of all these adverse events and subsequent other diseases, whether it's diabetes, osteoporosis, cataracts, thinning of the skin, gut perforation, all of these other things that we then have to worry about because we could not just effectively control disease because you came in a storm. So yes, the patient ultimately suffers and bears all of these risks when we miss and when we delay.
Jami, what do you think?
Yeah, I couldn't echo that more of how much similarity there is across all of our disease states, but the same thing with patients with ulcerative colitis and Crohn's disease. The delay in diagnosis is real. Many of these patients for years are labeled as irritable bowel syndrome as opposed to looking for inflammatory conditions that might be causing underlying symptoms. And then the challenge is that oftentimes these patients get exposed to maybe inappropriate or ineffective therapies. They may get steroids, but without a rescue strategy. So no steroid-sparing therapy is discussed. And so they go intermittently on steroids for many years before they get exposure to appropriate effective therapy. So that middle column, I think, rings so true is, first of all, making sure you have the right diagnosis and then finding that right patient for the right medication and the right time and the right dose. And for us in gastroenterology, we feel the same in terms of rheumatology is that delay in diagnosis, delay in starting effective therapy is associated with both short-term worse outcomes as well as long-term worse outcomes, including disability and need for surgery. So that damage, getting on top of that inflammation up front, that top-down approach where we used to step-up approach, right? You'd had to earn your therapy. We're moving away from that, where patients really getting the most effective therapy up front is actually what's most important for our patients.
Yeah, I really agree with that philosophy. In dermatology, a lot of people will come in and say, well, you're a dermatologist, you just treat the skin. There's no serious diseases or there's nothing that's going to have any serious risk. And I think we all know that that's not true. In the case of atopic dermatitis and psoriasis, and I'll even throw in hidradenitis suppurativa, what we're learning is that there's significant risk of systemic inflammation that's unchecked or untreated. We know now in the pediatric population of atopic dermatitis that if you don't treat the atopic dermatitis systemically, that you actually can get growth reduction or halting or stunting of growth of these children. You can get decreases in bone demineralization. And so by treating that inflammation, you now restore bone mineralization, you now restore the growth of these children. And then in older adults across psoriasis, atopic dermatitis, and hidradenitis suppurativa, there's increased cardiovascular risk from that systemic inflammation. And more studies are looking at when we intervene, whether it's biologics or oral JAK inhibitors, does it actually reduce cardiovascular risk outcome? And there's been some recent studies in psoriasis showing absolutely that IL-23 inhibitors combined with statins actually have some of the highest rates of reduction of cardiovascular risk in psoriasis. So Grace, you mentioned steroids, and I think all of us mentioned steroids, and steroids are incredibly widespread, ubiquitous in their use, but as you mentioned, they're dangerous. Both of you, what do you believe is a responsible ceiling for systemic steroid exposure? And how quickly should we be moving to steroid-sparing agents to replace them?
So, in my world, it's two-part. And just before we dive into that, there's one other aspect here that I think we have to highlight. It's when we come and we find the patient, we make the diagnosis early, we have a treatment strategy that works. But because, there's so much fear about being on advanced therapies and these, very, very powerful drugs, patients are reluctant because they know that steroids work. My grandmother got steroids and she walked again. They don't know that she then broke her hip because of subsequent osteoporosis. And so it really is sort of, as I say, doing a risk balance presentation where you understand the risk of disease, the risk of the easy therapies, and then the risks and the benefits behind our more targeted strategies. Because in my world, the real ceiling is 0 for prednisone. We use it because we have to. And, tongue in cheek aside, it depends on what we're treating. When you have somebody walking in with life-threatening lupus, life-threatening vasculitis that's affecting the brain, the heart, the lungs, everything is in shutdown, you pulse. You go to a gram if you need to, IV pulse. Other than that, we want to be less than 3 milligrams, right? So there's a hundreds of fold difference between what the appropriate ceiling is based on the presentation. Mm-hmm. And so it's important for us to recognize the danger, and the thing that we're afraid of is the danger of irreversible damage. The kidneys are gone. This person is blind. This person's lungs are, that is kind of when we go to these high doses. And then really now the idea is to rapidly taper in a matter of a few months, rather than having patients on therapy with steroids over the course of a few decades. Those days should be behind us because, as you said, we're conferring additional diseases when we have patients on long-term steroids.
Yeah, you make some great points. And I think, dermatologists and gastroenterologists are a little bit luckier in the sense that we have access to non-systemic corticosteroid-based therapies or steroid-based therapies, either in the form of topical steroids, in the dermatology practice, which often maybe in severe disease is not very effective. But, for us in gastroenterology, we have, gut released, budesonide, both for ulcerative colitis and Crohn's, and we have parectum therapy. So we can have some bridge therapies to that next step that maybe don't involve systemic steroids, but steroids are available to us when we need them. I think the challenge is what is the risk of under treating or not treating disease, and opposed to getting effective therapy, but with always an exit strategy. So any patient, if we're considering using a corticosteroid systemically, there always has to be a plan to exit wherever needed. And again, that effect, it depends on how sick that patient is and how dependent they are on that steroid and how long that effective therapy we are recommending takes to really kick in. But I think, what's great now is some of the newer mechanisms of action and some of the rapidity of onset of these mechanisms, as opposed to some of the therapies that maybe took a little bit longer in practice. We can sometimes avoid corticosteroids, or we think we might be able to avoid corticosteroids, especially, when we think of the rapidity of onset of some of our biologics as well as our JAK inhibitors. We might not need to reach for steroids for every patient if we're looking for that rapid onset of inflammatory control.
Jami, I really like what you said about steroids. And in dermatology, it is really common for patients to come in and they have just been chronically cycling between course and course and course. And in dermatology, we really don't have guidelines on an exit strategy. And
Right.
that has been a huge problem for clinicians to know when to exit the steroid cycle and go on to an advanced systemic therapy. And to that end, at least in atopic dermatitis, we have just published a position paper ahead of guidelines that actually align with the Endocrine Society to try to limit steroid use or define short-term steroid use as 3 to 4 weeks or less, and anything longer is a long-term course and really should be avoided at all costs, and you should be moving to advanced systemic therapies.
It's ironic, right, that we're now recognizing the impact of the inflammatory state of chronic obesity, but we're driving it by having patients on chronic steroids. So, we sort of have to figure out which end we're going to work with here and remove the cause as well as get more effective therapies. But well said.
And I think we forget, and something I emphasize to patients is long-term use of corticosteroids is really the only therapy that we use in our practice that is associated with an increased risk of mortality. And so when we think about weighing safety and how many steroid prescriptions are given and no hoops are needed to jump through to give us therapy that actually has real risk for patients, not only from just obviously the impacts on the body, but also for mortality and infection risk, but that we have to jump through all these hoops to be able to get these effective therapies that actually are safe and definitely safer than long-term steroid exposure.
So speaking of some of these alternative advanced systemic therapies, we're going to talk about a few different classes here. Here we talk about anti-IL-12/23 inhibition. What we can see on the right of the screen here is just ustekinumab. It's able to target the P40 subunit that's common between IL-12 and IL-23, at least in the dermatology space, treating plaque psoriasis. We can control the IL-23 dependent pathway, as well as IL-12 is involved in an IL-23 independent pathway that can lead to upregulation of IL-17A, F, TNF alpha, which can drive the psoriasis pathogenesis. So in the gastroenterology and rheumatology space, how are you seeing IL-12/23 inhibitors today?
Go ahead, Jami. I think
I mean, we use, and you're going to go on next to talk about the next class, which is the more, targeted IL-23 therapies. We have head-to-head studies have looked, at least in Crohn's disease, of looking at IL-12/23 versus IL-23. But, this is a very effective strategy in both Crohn's disease and ulcerative colitis in bio-naive patients. And some of the studies, at least post-marketing, have shown that patients that have not been exposed to multiple other biologic therapies seem to do best on these particular therapies with moderate to severe disease. So these are still very effective therapies that we use. And especially when we think about some of the crossover between, your conditions that you're treating in your practices. If those patients come in with multiple immune-mediated diseases, this is always an effective option for us, both for induction and maintenance in patients who are either steroid naive or steroid dependent.
Yeah, and that's, when the patient comes into my office with, they're walking in with inflammatory arthritis and they have inflammatory bowel disease, having an agent that crosses both organ systems and effectively targets that. And often then they'll have psoriasis as well. So they're in all three offices. And it's important for us to coordinate and collaborate so that we're not dividing up this individual into organ systems, but we're having this holistic approach to say, what is the single best therapy or the minimal number of agents needed to control your disease effectively and get you into remission? For me, that's the goal, right? Remission, absence of disease, avoidance of damage. And so the 23 class, very helpful. We see here in rheumatology, we primarily use this in active psoriatic arthritis across an age spectrum. So it's been very helpful, especially when we have this crossover.
Right. So when you both mentioned the idea of treating multiple diseases at once. So when you have patients that have sort of this polyphenotype disease, if you will, where they, for example, atopic dermatitis and inflammatory bowel disease, or they have axial arthritic disease plus psoriasis, how are you viewing using a single agent in terms of being strategic and clinically superior versus a multi-agent regimen? How are you deciding which is going to be best for the patient?
I think sometimes it's based on whose office you walk into first, right? Because sometimes you come into my office, you've got psoriatic arthritis. You have no GI symptoms. I put you on an interleukin-17 inhibitor, and lo and behold, you have Crohn's or ulcerative colitis. So that is not an appropriate therapy for you, whereas for the person who doesn't have that, it would be. So again, it's a starting point, or I'll see somebody who comes in with Crohn's disease that looks great, except their spine is completely flared. So we need to come up with a strategy that covers both. Unfortunately, we have some agents that cross multiple domains because of the level at which they work, but not all agents do. And so I think that's the nuance and the science behind what we do. So I'm going to leave the room from rheumatology, and they walked into GI first. So Jami, what do you do?
I think it depends on, so you're right. And oftentimes it's really that multidisciplinary approach. And I think if that patient has undifferentiated or undiagnosed inflammatory arthropathy, or if they have a rash of, undiagnosed rash, and they're also having gut related inflammatory condition, I think really if they have two very clear diagnoses and they have not established with one of my partners, I'm certainly reaching out right away, but also looking at which of these diseases is having the most significant impact acutely in terms of quality of life, and which one is at the most risk for long-term disability, because that really, I think, helps guide it, because there are certain therapies, let's say in a patient with, maybe psoriasis, but also has severe Crohn's, severe penetrating disease, perianal disease associated with the worst quality of life, and steroid dependent, maybe it's failed a TNF-based therapy. We have data that there are certain of our advanced therapies that might be more effective in that particular phenotype when somebody has maybe not done well in a TNF in the past. And so that may drive us a different way and maybe help us select it from my disease state. And maybe we try to capture it. Maybe it's not the best therapy in your disease state, but that's not where the disability is maybe the greatest. So I think it really is kind of which disease state is driving, most of the disability in this particular patient.
Sure. So Jami, let me turn to you as the gastroenterologist. What are S1P receptor modulators, and how are you using them in gastroenterology to manage UC?
Yeah, and so these are newer oral therapies. We have two, etrasimod and ozanimod. Ozanimod was approved first, and etrasimod, they both block S1P in different ways, as you can see by the image. And essentially, the best way to think about it is they trap lymphocytes in the lymph nodes. And we know that these conditions are driven by inflammation, lymphocytes, other related white cells. And so these are effective therapies. They're a nice oral option. They were our first oral option for many patients with more mild to severe disease, although they do have an FDA approval for moderate to severe disease. These might be the patients that are reluctant to go to a biologic, maybe misinformed or misguided in that reluctance, but reluctant to go on to a biologic because it seems a more significant treatment, want to stay in an oral therapy and want an effective oral therapy that is shown to be effective in patients that have steroid history of steroid requirement or history of failure of maybe mesalamine therapy. They feel better about this, but it is being currently studied in phase 2 in patients with Crohn's disease. So we might see another indication. And S1Ps actually have been around and have been looked at in neurologic conditions. I know a little bit outside of our specialties here, but we do see patients that present that have other neurologic related immune mediated conditions, and this might be a good on patients.
Excellent. So we sort of talked about IL-23 already, that there's a more targeted, right, a P19 subunit focused IL-23 inhibitor class. How are you both using in gastroenterology and rheumatology IL-23 P19 specific biologics? And what's your experience using them across Crohn's, UC, and psoriatic arthritis? How do you know which of these to choose from?
Well, for some, it's a matter of how quickly do you need to get better, even if your disease is this severe. And I when I say that, I mean that person who has to get up and go to work the next day and does not have, a long time to get that response. Sometimes I'm looking at the kinetics of that response. How quickly will they get a 50% improvement, a 70% improvement? And that determines for that patient which choice they'll accept. But from a class perspective, we're thinking about the same general categories. Where we don't use the 23s is when we have somebody who's got spine involvement as well as peripheral disease, because that is where we see the separation in terms of where they don't work as well in the spine for our particular inflammatory arthritis.
I think you asked kind of which one, because we're lucky enough to have 3 approved within both Crohn's disease and ulcerative colitis. And so I think really, to be honest with you, to be completely frank, it's which one we can get access to, right? Because getting patients on therapy is the most important part, and there is variable access across different payers with these therapies. The Gilsukimab just recently got approval for both sub-Q induction for both Crohn's disease, which was first, and ulcerative colitis in the last couple of weeks. And so oftentimes with a commercial paying patient, we can get access to therapy based on this sub-Q induction, not this dual approval that we've come to learn about with both IL-12/23 as well as IL-23s, where we have to do IV and then sub-Q. With doing sub-Q, both induction and for maintenance, that we can get access to therapy pretty quickly. If we think this is the right therapy for that particular patient, getting access to therapy is really the most important for me.
Okay, excellent. Let's dive into JAK inhibitors. JAK inhibitors have sort of revolutionized dermatology over the last few years, and I imagine gastroenterology and rheumatology as well. We have a number approved in atopic dermatitis, TYK2 inhibitors, and psoriasis, plaque psoriasis, soon to be psoriatic arthritis as well, and now alopecia areata, hair loss. Where has a JAK-STAT focused approach really proven versatile across your fields? And is there any place where you would still favor organ-specific biologics, or do you feel the JAK inhibitors are really taking over in treatment of some of these diseases?
Well, I think it depends on where, as you said, where the danger zone is, both in terms of what the disease is doing, but also with the comorbidities that patient walks in the room with. Patients come in, as I say, with luggage. They come in with suitcases filled with other things. So my 62-year-old who has a strong family history of heart disease, who is kind of sedentary, who's hyperlipidemic, who's been smoking and is hypertensive, walking in with a cardiovascular risk profile, I think of them differently than my 22-year-old. Who doesn't quite have that size. They just have a tiny carry-on versus a check-in luggage. So we have to stratify risk. And I think, with some of the recent safety, post-approval safety surveillance studies, there's been a lot of attention based on cardiovascular risk, malignancy, and thrombotic risk with both DVTs and pulmonary emboli and arterial thrombi. Because when we look at our high-risk group, and this is a cardiac risk stratification, that's where we see this. I think we have to think of who that person is. That aside, when I think of small molecules that are working at the level of the receptor inside the cell, the first thing, that my PhD brain goes to is, now I have left the exterior where I'm limited by what that ligand receptor interaction is. I can now think about things that will work truly across the spectrum and disrupt multiple pathways. So that person who comes in, who has a disease that involves, let's say it's axial spondyloarthritis, he's got inflammatory bowel disease and inflammatory skin disease. Well, the one thing that sort of cuts right across besides our biologics like TNF would be a JAK inhibitor. So again, number one is for me to recognize that there is something else outside of my domain, and then to think of the pathways involved, and then to think of the urgency, what's at risk, where is damage going to occur, and I always go to what can I recover from? If I miss it, what is non-recoverable? And the JAKs have allowed us to really to do that. And then Jami, you mentioned about access. Well, I'm also thinking in terms of how quickly will this get up to a therapeutic levels and start working? It's what I call the twitch. When are you going to feel that something changed? And then when I'm going to document that something has switched so that your disease is better controlled. So I think JAKs have revolutionized for me how we think about pathways and how we think about diseases that sit in our specialties, but also adjacent to those specialties in that single patient.
And I think, a lot of the post-marketing analysis across upadacitinib in particular, and as well as tofacitinib within GI, really didn't show some of those similar patterns or concerns about risks with venous thromboembolism or PE or even mortality that was seen necessarily in the oral surveillance study, which was tofacitinib in a high-risk rheumatologic population also exposed to methotrexate. So I think that, I'm not fearful of using a JAK in a patient, even when they have some risk factors. Where I see the limitation is oftentimes our patients, many across all of our disease states, are childbearing women. And we don't have a lot of data in that particular patient population about safety and actually some concerns about potential exposure during pregnancy. So when I'm thinking about this use, I'm thinking about this use, it has to come after a TNF, at least based on how the FDA has labeled this. And now, sure, many people have used it differently, and we were using it differently before the FDA label change. In a really sick person in the hospital, this is a rescue therapy for us in patients with ulcerative colitis. And so it's actually been shown to be even as effective as steroids in an inpatient population. Right. So these are our sick patients that we're using, JAK inhibitors in, but maybe we shouldn't be just reserving them to the patients that have failed all of our advanced therapies and then this is our last resort. Maybe there's a way that we should be considering positioning these differently, and it's at least how we're talking about it in gastroenterology.
Yeah, and the nice thing when you look at the data is that I say this is agnostic of the patient journey. When you look at those patients who are early or late, have failed therapies, you still see effective responses, at least from our measure sets, our outcome measures, and from patient-reported responses that are equivalent. So I tell patients, it doesn't really matter how long you've been trying because people give up. And they get sort of despondent and distressed. There's an opportunity for improvement. And so I really think about these and how we talk about these and present them to patients, because not everything is rheumatoid arthritis, which is where this was studied. Everything else is very different, even our background data set. So yeah, totally agree with you.
So one of the questions I wanted to follow up on, you talked about how, and I love this description because this is how I describe it, the JAK inhibitor is working inside the cell, right at the signaling pathway, right at that cytoplasm to nucleus interface. And we think in dermatology, or we talk about the quick onset of action of the JAK inhibitors in treating atopic dermatitis, or even less quick in terms of alopecia areata, but even in psoriatic arthritis. Are you seeing in gastroenterology and rheumatology this quick onset of action in your diseases as well?
I mean, yeah, the inpatient use is showing you that we're getting response within days. Some of the data have shown as with early as 3 days, which is remarkable. And we're seeing in the outpatient setting too. And remember, we use higher doses. And so oftentimes when we have these joint patients, we're often piggybacking off the dosing that we're using in inflammatory bowel disease because it is at that higher dose. And so maybe we're even seeing greater response across different disease states with JAK inhibition use.
Yeah, absolutely.
I'm really glad you brought up the higher dose, because in dermatology, I don't think all dermatologists are aware of the higher doses that are used across your specialties of gastroenterology and rheumatology. And I think that's incredibly helpful to understand, because in terms of safety, what we're seeing in dermatology, especially in atopic dermatitis, is that when you stratify patients based on cardiovascular risk factor, patients that receive upadacitinib in a recent study actually fared better, had lower rates of MACE, VTE, and malignancy than patients that were not on a JAK inhibitor therapy. And I think that we're seeing almost a more reduction in these adverse events in patients that are on the JAK inhibitors, which I think is incredibly important for people to understand.
Yeah, we have to think about the person as a whole composite, not just an organ system. Right. And I just remember as a trainee, as a fellow, having a young woman come in with lupus. She'd been on steroids for decades, and she died in her 40s of a massive myocardial infarction because her therapy was what ultimately destroyed her coronary vessels. So this person comes in with tons of things, and we have to really sort of think through this. And again, going back to what do we have that's been studied in women of childbearing potential so that we can control their disease across their entire reproductive journey.
Yeah. So we're almost up on time. I have two final questions. One of the things that I wanted to ask was, are there any specific cross-disease biomarkers that you find particularly useful in managing your decisions?
I mean, I think what's great about your disease state is that the skin is so easy to see, right? So people just walk in and there's not, we have a little, I don't think across disease states. I mean, I think we all use C-reactive protein, but we know
Right.
that it's not selective, it's not specific. And in fact, there's a good proportion of patients, depending on what their inflammatory state is, may not generate a C-reactive protein. So you have to know what their baseline is. Within IBD, we use fecal calprotectin. That's also maybe, again, specific to us. And then we're using a lot of intestinal ultrasound in our practice to be monitoring for inflammatory change. But none of those things help my colleagues in rheumatology or dermatology. So I'm jealous that the skin is so accessible and easy to see. But ultrasound is changing that in our practice.
And I'm jealous of both of you. So, sonography is very helpful when we're looking at infeasial and dactylitic. But here's a problem for us, right? Once you've got damage in a joint, you may have pain reported in that joint and enlargement that appears to still be active disease. And so teasing out what's damaged versus active is hard. And CRPs and SED rates can vary for a variety of reasons. We have lots of serologies and autoantibodies that will tell us, what this is. And now we're beginning to develop biomarkers and composite biomarkers, most importantly, because we're multi-organ, whether it's systemic lupus or rheumatoid arthritis, that can monitor disease activity that will include inflammatory cytokines that cover all of our diseases. But we have to know sort of how does this vary when we get into remission from any particular one. So it's a complicated world, and I'm actually thrilled to be a part of it.
So I'm glad you mentioned pain, Grace, because the last question I wanted to bring up before we have to conclude tonight is the incorporation of patient-reported outcomes. In atopic dermatitis, PROs are being incorporated with clinician-reported outcomes to actually define composite optimal treatment targets and guide achievement of minimal disease activity. So how are patient-reported outcomes being incorporated into the GI and rheumatology management algorithms?
I mean, I think we're seeing that as well. And we have a treat to target strategy, and that treat to target strategy involves both early assessment of patient-reported outcomes, early in treatment response, as well as looking at more of these objective things like C-reactive protein, fecal calprotectin, intestinal ultrasound change. Ultimately, we are treating to healing, absence of ulcerations, absence of inflammation on endoscopy. But more importantly, we're treating to long-term goals, which is overall improved quality of life. So I think that's similar, and reduction of complications. So I think everyone's reading the same book where we're all focused on what are not only the short-term things, we want you to feel better, but how can we change those long-term outcomes as well? So it sounds like we're all very aligned with that. And it's important that we are asking patients about these things that are validated so that we can start to track them.
Yeah, so we've been, using patient-reported outcomes because for a very long time, that's all we had. Ask the patient, how do they feel? And we go by that. But we're sort of shifting now is to have patients tell us what matters, so that the patient-reported outcome is based on something that actually is meaningful to the patient. Because, often we create these abstract sort of settings. We think of function, for instance. One of our hack DIs where you're talking about function, the New Yorker walking up and down, 3 flights of subway steps, and the person driving for 3 miles in a car have very different functional requirements. And so we have to be sensitive to all of these shifts that occur and then find things. But you're right, it has to matter to that person because they're living that lived experience. And it has to be part of how we monitor progress for our patients.
I do think that there's so much emphasis now on quality of life in terms of being able to really make sure that the therapies, all the advanced systemic therapies that we've been talking about, really get patients as close to an optimal treatment target or a minimal disease activity state as possible. And I do think that that's going to be the wave, even using higher endpoints in clinical trials to potentially really also, as we have more innovation, more therapies flood the market, you have to distinguish them. And so having these more stringent endpoints can be a way of really identifying which therapies are going to benefit the patients most. So with that, I'd like to conclude and thank you both for joining me on this educational program. And thank you to our audience for participating in this activity. Please click the link below or go scan the QR code on the right to get your CME credit. And thank you so much for joining us this evening.
Thank you.
Thank you for having us.